Good evening to all of you. And Critical Care Foundation is the trust which is dedicated to the help of critically sick. During last 15 months, almost 15,000 doctors and nurses have been trained free of cost in management of COVID patients throughout India. And about 2,000 plus doctors have been trained in knowledge and skill of critical care medicine on highly subsidized fee on no profit, no loss basis. As many as 25 sessions of public interest have been organized free of cost, mostly concerning to COVID, its implication, management, etc., etc., and lots of flyers have been sent around in the country to educate people at large about COVID. Ladies and gentlemen, let me give you a preamble of the issue. Why are we here together this evening? The second COVID surge has really hurt India, and it has hurt the whole country under the belt, if I may be permitted to say so. More than almost 400,000 cases are reported every day, and we have more than 5,000 deaths reported. The figure can only be higher. These are official figures. It's massive by any definition. India was definitely not prepared and ready for this. On the top of this, there has been a biological onslaught of and problem of misinformation, disinformation. Media has only added fuel to the fire. Rush to get a hospital bed, initiate oxygen therapy, unscrupulous prescription containing everything one can imagine, including remdesivir, ivermectin, favipiravir, HCQ, azithromycin, and whatnot. Patients are thronging imaging centers and diagnostic labs for HRCT chest, what we call here popularly CT scan chest, and a battery of tests even before diagnosis is made. Every positive patient looks for remdesivir injection. And the worst are the most important people of the country, most educated, the wealthy ones, the resourceful ones, and each one of them, if positive, must get remdesivir whether they need it or not, whether it is available or not. That has only sent a very strong and bad message downstream in the middle class and the lower middle class seeking remdesivir as a magic cure. The medical professional, I must confess, have worked very hard and given their 200%, but the top brass in the country amongst them who are supposed to give correct information and direction to the people about COVID have fallen short of their expected role. The right voice has been lost into the noise of fearmongers. It is of late that we are hearing much needed right correct information from only few of them, and it is too little too late. The damage has already been done. Therefore, today's discussion and multinational perspective being offered to you, to our guest audience, and I'm sure that they would seek a lot of clarification from our panel today, and I will leave it free for the panel to address their queries and questions. Ladies and gentlemen, we will confine ourselves mostly to pre-hospital requirements, advices, and recommendations. I will request my panelist colleagues and the audience not to discuss about what to do, how to do after hospitalization of the patient, because it is the prerogative of the doctor or the medical team treating the patient to do or not to do for the patient in the hospital. Largely, the misinformation, disinformation is affecting the psyche of the people. Only those either are seeking hospitalization or do not need hospital at all. Therefore, the purpose of today's meeting is largely to clarify here who needs hospitalization, who needs investigations, what is the status of drugs like ivermectin, doxycycline, remdesivir, a little bit about vaccination and the demand of oxygen. We will largely try to confine to all these areas. For this discussion, we have an eminent multinational panel with us. We have Dr. Rose Freeburn from New Zealand, who is, I'm very thankful to Rose, to you for being with us, because it is past midnight in your country. It must be around 2 a.m., something around that.
Yep, that's right. Yep.
Right. So I was really hesitant to disturb you, but the cause was such, and I know your mind and heart, you are always ready to help. So Dr. Rose Freeburn is the intensive care consultant at Hawke's Bay Hospital in Hastings, New Zealand, and the immediate past president of Asia Pacific Association of Critical Care Medicine and past president College of Intensive Care Medicine. He is an adjunct associate professor at the Chinese University of Hong Kong and medical director of New Zealand Air Ambulance Services. Professor Freeburn is the Associate Dean, Hawke's Bay Campus University of Otago Medical School, and a member of Basic Steering Group, and is involved in course running in New Zealand, Australia, Africa, Asia, Middle East, in the Pacific and Europe. He knows India and the Indian mind and heart more than anyone else, because as far as I know, he has traveled at least 50 times to India during last 25 years. So his mind and heart is quite close to all of us. Then we have Professor Kurono. Before that, let me introduce Dr. Girish Sharma. Girish Sharma is alumni of SMS Medical College, Jaipur. He is currently located in Connecticut, USA, a US citizen for last 40 years almost.
Yes.
He has been invited here because during last 1.25 years, he has been involved in active management of COVID cases in his hospital. He is the chairman of Department of Medicine, chair non-interventional cardiology there, and he is largely looking at the management of COVID, mild to moderate cases in his hospital. And he has been a source of a lot of information to all of us from that area. We have Professor Dr. Abhinav Gupta. Dr. Abhinav, can you raise your hand, please?
Sir.
Dr. Abhinav Gupta is he's located in London. He is consultant Homerton Hospital, London there, and he's involved in a lot of research work, active research work going on in COVID for last 1.25 years, and has been the frontline warrior in management of COVID there in England. And he has been a source to us for a lot of current research that has been going around in the Western countries. Professor Kurono Parsivali. Kurono, you are there? Kurono?
Hello.
Yeah, can you raise your hand, please? Kurono?
Okay.
Yeah.
12.
So, yeah. he is the visiting professor, University Campus Biomedico, Rome, Italy. Visiting professor, University of Saint Cyril Methodus, Skopje, Macedonia. Head of Department of Anesthesia and Intensive Care at St. Filippo Neri Hospital, Rome, Italy. member of Scientific Board of COVID-19 of India, Indonesia, Japan, President of World Scientific Society of Anesthesia, TIV, TCI, and he is consultant to President for Clinical Risk Society. Holds many other portfolios, and thank you very much specifically to Dr. Kirono for finding some time. He's to attend a conference which is going on at the Vatican City today. We also have a media person today,
Yes.
Mr. Swatantra Jain, who has been carrying out a lot of programs on COVID lately from one of the TV channels in Jaipur. The purpose of inviting him is to get the first-hand information what the world is thinking about COVID in the current scenario, particularly for the pre-hospital patients. So he will get the first-hand information, and I'm sure he will be able to filter the information to be passed to the public at large as far as what is correct and what is not correct. And last but not the least, we have Dr. Banambare, one of the senior most guys in this country, Guru of Gurus, and who's retired as head of department of Tata Main Hospital, Jamshedpur, currently located in Bhubaneswar. He has been teacher to many of us and a veteran, now is a frontline warrior in Odisha, a teacher, clinician, Dr. Ray, most welcome. And then we have lots of eminent citizens from our own country. I can introduce a few of them. We have Justice P.C. Jain. If you can
Good evening,
sir. If you, the host can focus, Justice Panachanji Jain. Is the retired Justice of Rajasthan High Court and doing a lot of social work in this part of our country. He is 94 and works almost 14-16 hours a day. I'm very happy to have General Anuj Mathur, who headed the North Zone Army headquarters in India for a long time, and he's currently located in Jaipur. He's also involved in active social work. And then I have a lot of my colleagues from intensive care, medicine, surgeons from Jaipur and other parts of India. I have some of my old class fellows. I have Rajendra Kapoor. He was my schoolmate in Calcutta way back in 1970. I have Pradeep Devda, who was my classmate in Calcutta during the same period. I have some class fellows. I must tell the crowd that Girish Sharma has also been my class fellow, a batchmate during my MBBS. It's another matter that today he is in Connecticut involved in COVID patient. So without
also Mr. Ashok Parija, the Advocate General of Odisha.
Okay. Advocate General Saab, Parija Saab, you are most welcome.
Thank you so much.
Yeah, and so now can I share the screen, the host, Shekhar?
Yes, sir. Yes, sir.
I just want to show one slide, just one clip. You don't see that clip? I will have to share it again. No. Probably I'm unable to bring that to the fore. I Shekhar, I am unable to share the screen. No, it is not my screen. All right. Yes. Now, can you see this small clip?
Yes.
Yeah, this is in Hindi, and I will translate it into English for my uh, English friends, English-speaking friends. This says this made the headlines in one of the local dailies in Jaipur.
6 मिनट वॉक करो
6 मिनट वॉक करें, ऑक्सीजन सेचुरेशन 4 से 5% घट जाए और लंग्स में सीटी स्कोर 8 से ज्यादा हो तो अस्पताल की जरूरत. That was described as the indication for hospitalization for COVID patient by the top brass government spokesperson. Ross and Kurono, this meant that the indications for hospitalization are 6 minutes walk test leading to desaturation or HRCT score of more than 6 or 8. Now I'll first straight go to Ross. Ross, can you unmute yourself?
Sure.
And yeah.
So
and,
it's
express your mind on this.
it's concerning. I think any scoring system that for a complex disease that says you need to go to hospital is going to end up with a lot of people presenting that don't need to be there. I would have thought that the indications to go to hospital is when the hospital can provide you with something that you cannot get at home. There are two arms of COVID. One is to reduce the infectivity to others, and the second thing is to make sure people that have it have access to as much care as they can get. Now, if we send everybody to hospital that has a certain score, and many of those patients aren't going to benefit from our treatments, then we're going to clog up the hospital system with people that are going to get no benefit. And that's going to deny people who do get benefit access to it. I must say that your system, your situation sounds very dire compared to New Zealand, where we've been spared an onset of COVID. We're basically COVID free, but the things in India sound quite tragic, really. And I think we have to be careful if we're going to recommend treatments that those treatments work, and not to try and treat people just because treating them makes us feel better.
World Conference, critical care for COVID.
So one of the important things that I think we need to understand is that the oxygen, which sounds like it's a major problem, accessing oxygen is important because it prevents hypoxemia, prevents patients being hypoxic when their lungs are damaged, but it doesn't make you better. So if your saturations on a pulse oximeter are greater than 92, then the oxygen will not help you. And those patients don't need to be in hospital and they don't need to be getting oxygen. However, when their saturations do fall to below 90, they will need oxygen. And it would be better to maintain oxygen supplies for those that need them rather than giving them to people when the saturations are a little bit higher, thinking that it makes them better. So there's sort of my initial thoughts on where we should be going. It doesn't appear that any of the medicinal treatments that we've been tried seem to have any great effect in reducing either the spread or the course of the disease in an individual. And so therefore, particularly antibiotics, we should avoid giving antibiotics to patients unless there's an absolute indication to do that. As Narendra has said, there are other simple things we should be doing, making sure patients are hydrated. They should take simple paracetamol if they're symptomatic, if that makes them feel better, recognizing that paracetamol won't make them better, but might make them feel better, particularly if they have a high-grade fever. But hydration is the other thing that's important, and that can be achieved at home with oral hydration. So the indications to go to hospital for me would change, but I think they would be when the hospital can provide services to the patient that can't be provided at home, particularly with the demand on hospital beds at the moment. We need to take a thought that perhaps not going to hospital is a safer thing to do than going to hospital.
So thank you, Rose. Just summarizing what Rose has said. Rose, you may correct me if I go wrong. Rose means that you need to go to the hospital only if you need to get services which are not possible outside the hospital or in your home, or your oxygen saturation falls below 90. Is that right, Rose?
Yeah, yeah. I think at 90 you would need oxygen. So
yes,
at 92,
90 or below.
Yeah. At 92, you sort of think about going to hospital because it may continue to get worse. But I wouldn't be giving people oxygen at 92 or 94. I would say that they've.
Third, no antibiotics are needed. We need to just maintain good hydration. No antibiotics are. And straight away, I will go on to Dr. Abhinav Gupta, who is in Homerton Hospital, London, and he's involved in very high level research. The part of all those research groups where remdesivir was researched, role of steroids have been researched, and they have been practicing a very, very disciplined mode of protocol. Who should be admitted to the hospital, who will get remdesivir, who will get oxygen, etc., etc. And Dr. Abhinav has worked in India for a long time, and it is last 5 years that he has settled down in UK. Dr. Abhinav Gupta, your opinion about the questions that we have raised.
Thank you, sir. Thank you very much for inviting me to this one. I think the questions are very relevant. Is the first thing that we are always worried about, which Ross has wonderfully mentioned, is who should be admitted to hospital. And this is very valid because in India, as we all know from the news and whatever the entire world is hearing, is severe shortage of beds, severe shortage of oxygen, and everybody is running towards CT scan, severe shortage of remdesivir. I think it is a very valid point that all those patients who are maintaining a saturation of more than 94%, please do not come to hospital. You can easily manage yourself at home, because coming to hospital has its own risk to the patients themselves and to their family members as well, because they'll be visiting these people in the hospital. So you're exposing yourself more, and you're exposing your family members more to the diseases. And second thing is targeted oxygen saturation of 90%, which is a very valid point. This is what we followed in the UK. Is all oxygen the targeted saturation should be 90% and not 92% or 94%. This would very well help you in conserving oxygen in the hospitals and help to the community as well. Because we know in India there is severe shortage of oxygen. The next point was about the CT scan. Please do not get your CT scan done unless or until advised by the doctor. This is not indicated. A CT scan of whatever the scoring is, it is for the doctor to judge, please. So even the doctors, please do, unless you're symptomatic.
You are muted, Abhinav. Please unmute
Sorry.
yourself. Yeah.
I'm sorry. So the only thing is, please do not get a CT scan unless advised by the doctor, unless you are symptomatic. So the most important thing is a plain X-ray will give enough information, and if necessary, from prognostication point of view, a CT scan would be required. The third thing that you mentioned, sir, was remdesivir. Yes, WHO solidarity trial was a big thing. It said remdesivir has no role, but still there are a lot of studies going on which showed otherwise. So remdesivir in the UK is, as per protocol, is only indicated in the first 10 days of symptoms. After 10 days, we do not advocate use of remdesivir in the entire country, basically. So I think please do not run after remdesivir. We know from news and from our relations in India is there's a severe shortage of remdesivir. Please do not give remdesivir to each and every patient beyond 10 days. It is not indicated. And the fourth thing was about steroids. I think be careful when you use steroids. In all mild cases, I've been talking to a lot of my friends everywhere in the UK as well, as per protocol. Do not use steroids if in cases of mild diseases. Only if you are symptomatic, if your oxygen saturation is low, and if you are requiring respiratory support, only then steroids are indicated, and that too only dexamethasone 6 milligram per day or hydrocortisone 100 milligram etally, which has been extensively studied. I think I would insist that there's a lot of research going on at the same time. REMAP-CAP trial, recovery trial, which were the major trials in the UK. They were studying a lot of drugs at the same time. It's a very interesting research. If somebody is a student of research, it is worthwhile going into the way the research was conducted. It's just like I would take it just like octopus. You have multiple arms being studied at the same time, and then and the evidence is collected around that. And I think the only thing that has come out of it is steroids and tocilizumab, and that too tocilizumab within first 24 to 48 hours. Please do not give tocilizumab beyond that time. Again, there's an immense shortage of tocilizumab in the entire country. So please do not give tocilizumab routinely. It is not routinely indicated. Only in those patients in which who are 24 to 48 hours within respiratory support. That is all. Otherwise, you are exposing all the patients to more infections, because all these things, they decrease your immunity, and you are more prone for your fungal infections, for your bacterial infections. So the problem is you'll feel better at this, for some days, and then the sepsis takes in, and you are more exposed to bacteria and fungus, which eventually cause more harm. So be very judicious in using all these medicines. I think Kiruno mentioned a very good thing about staying positive, meditation, hydration. These are very important points to about your mental health as well. So staying positive and hope is the most important thing at this point of time, and protect yourself. Masks and hygiene are the most important thing to protect yourself. Be very safe. That is a very important message, I would say. And
thank you, Dr. Abhinav Gupta, for summarizing what is happening in your country there and what you are doing and what you are advocating to our citizens here in India. Now I'll go on to Dr. Girish Sharma. Girish, what is your opinion? You have heard about the questions. You have heard about what is going on. You know yourself, you've been talking to friends and relatives in India. But you are the frontline warrior there in your hospital.
So let me summarize. You know, what Abhinav has said is absolutely 100% true. That what it needs to be done. In United States, we had no problem about getting any of those things, but we try to curtail that which patient should get what. So we always have these protocols. Now I'm looking, when I hear from my friends in India, I get called practically every day. Many of these patients do not require anything. As I mentioned earlier, they just may require basically paracetamol. 85% of the population who gets COVID does not require any kind of intervention, then you would have been taking care for it like a common cold. So now it leaves you about 10 to 15% of the patient, whom another 5 or 6% patient will require moderate degree of care, which might require steroids or even remdesivir, and other are who requires ventilation, things like that. But what I'm looking at it in India is that everybody is getting a CAT scan. Just like you showed me the first slide, 6 minutes walk, CAT scan score of 8. I said, what do we do with those numbers? What would if it was 7? And what if it was a 13? Does it really? So I think the CAT scans are highly overused. Not only that, even all those, all the tests, C-reactive protein, IL-6, patient who has a very, very mild disease do not require any of these testing. So this is not what we are doing. Of course, now this big push is about vaccination. So 33% population of the United States are already been vaccinated. That means about 100 million people. By July 4th, we'll have about 70% people who will get vaccinated. That will definitely, so I think the emphasis is more towards the prevention, which will be vaccination. So I'm sure the government is doing as much effort as they can to, because the population is such a large, that they will do it as best as they can. But at this point, more important is to avoid patient to go to the, a lot of patients do not need hospitalization. And if we can leave those patients at home or some way, other way of care, that the more people who are really sick can be admitted to the hospital and their lives can be saved. Right now, because they're sick and there's no bed, people are dying either in the emergency room or in a parking lot. It is so sad to see those pictures. It breaks my heart. Do you have any particular question, Narendra, that you would like to ask?
Yes. 3 direct questions, and you can answer them in a very, very short answer, Girish. One, how many percentage of your patients receive remdesivir?
Very small percent. Very, very small percentage.
Well, what is that small?
The small percent could be even just 5 to 10%.
So
in the people who are hospitalized, these are the patients who are hospitalized.
None at home?
None at home.
Okay.
No.
So question number two, how many of your patients have received tocilizumab?
That may be even smaller percentage. But all these patients are, when they get it at the hospital, not as an outpatient.
Okay. Number 3 question is, how many of your patients got antibiotics?
Well, I have to admit that a lot of patients did get antibiotic because the physicians were either not, physicians were say, let's do something, because the patient were not seen in the office. Maybe he doesn't have a COVID, or maybe he didn't have the COVID test, but it was definitely got abused. And I have to admit, a lot of patients did get antibiotics.
All right. So here is the answer for our, audience who have, the attendance is really heartwarming, and we will request them to put their questions in the chat box, and we will invite their comments also. So it is very clear that only less than 10% patient would require consideration for hospitalization, require some treatment, not hospitalization. Out of those 10-15%, hardly 5% would require consideration for hospitalization. And none of them, probably, Girish has been candid enough to admit that antibiotics have been abused. Abhinav, come back to you for a second. How many percentage of your patients received antibiotics?
So to be honest, most of our patients were on steroids who were admitted to ICU, and some did receive tocilizumab because, as per the national
antibiotics.
protocol,
My question is about antibiotics.
Yeah. So basically, what really happened was that a lot of patients had positive cultures, and around 70 to 80% of ICU patients, not the ward patients, of the ICU patients, they were requiring
Let me
antibiotics.
alter my question.
Sorry.
Let me alter my question. Empirical antibiotics.
No, none. No, nobody was on empirical antibiotics.
Without evidence.
Without evidence, nobody was on empirical antibiotics.
So that was my question, and that is the answer you have. Now I'll go straight to the guru of gurus, Dr. Banamba Ray, to summarize the proceeding until now. what he has to say in about 1.5 to 2 minutes, Dr. Ray.
Well, I think thank you, Dr. Rumta. This has been an excellent exchange of informations, and something which I feel that what we are believing and doing, and that's what actually has been said. You know, mild cases, no treatment except paracetamol that we give if there is fever, if there is body ache, and nothing else we need to actually do. And if the oxygen saturation comes down below 90%, you give oxygen. If it is 92, 93, just observe, you don't waste oxygen, right? And this is what something which we must all of us know. And there is so much of anxiety, apprehension, saturation has dropped to 94, 93, and suddenly you must give oxygen, which is not true. I think it is not fair. And particularly when in India, we have got an oxygen scarcity, we should not waste oxygen. Remdesivir, as Dr. Gupta said, up to day 10. This means that you must start it on day 5 or day 6 so that it goes up to day 10. Do not extend beyond day 10, which is what we practice. We don't give remdesivir on day 8 or 9 and goes on for 5 days, which is not really right. Well, I think tocilizumab is something which Dr. Gupta said that we must give it in the first 2 days, if at all we give, but not certainly beyond. And to be very frank, I have not given. And even if the IL-6 is high, still I am quite skeptical about tocilizumab. And in my institution, we do not actually give. And if somebody has to give tocilizumab, we need to actually discuss. And this is what I would like to convey to the audience, to the citizens. Don't press for tocilizumab. This is something we should not actually, but very, very rarely, I think it has to be a collective decision that we should give. This is so far all about what we said. Hardly 5 to 10% of patients require perhaps admission, not all of them. But in India, we have got again a scarcity of beds, and therefore people are very, very insecure. If it is 94, they search for a bed in any hospital anywhere, right? That is all right because we are quite insecure, but certainly we don't require oxygen if it is 93 or 94.
Thank you, Dr. Ray. I must mention here that we have observed that when the patient gets worse and worse, does not respond to mechanical ventilation, consultant starts thinking of toci, plasma, at the last resort. So there is definitely some gap in understanding. There is a lot of misunderstanding. When to use what drug? What is the role of drug duration-wise of the disease? So now I will just sum up that we rarely need oxygen above 92% of oxygen saturation. There is limitation to the indications of remdesivir use. It is used in first 10 days. It is not a life-saving drug. Still remains a drug of research. WHO has removed it from the list of the drugs to be used in COVID patients. I'll march on to the last of our panelists, Mr. Swatantra Jain, media man, who is conducting a lot of these webinars on TV about during last few weeks. So I will request Mr. Jain to express his opinion, what he's getting on media from various speakers, and what is your view that he has made out. Please, you have one to 1.25 minutes to express your views. Mr. Swatantra Jain.
Thank you, Dr. Rumta, for inviting me and giving so much time. In fact, I have observation and questions, not much information to share. What I feel is that we are living in a time where we are experimenting with the 5G and trying to bring the 5G, but we are not able to share the data of the patient on the website or app, but they are doing with their patient. When you are saying you are in COVID, so I mean the patient relative and their man can't see the even the patient what doctor have been doing with them, but you should at least share their data on our website or app that this patient came on that day, this treatment was given to him, and this is what the followed him, whether he saved you could save him his or her life or not. So this is the data. We are having a government which making an app for everything, website for everything, but we are not able to so far had maintain any single platform where all the hospitals, all the doctors can come and report their patient history, that we admitted this patient came on that day, we give that this, because there is no protocol. So at least not only for the transparency purpose, we will have the research on that. We can get that related real data that what we have been doing with the patient. We can reach on the conclusion which medicine is working or not, which medicine is working as. So I think we can. This is a time that we should move toward the transparency of the treatment of the patient, not only to only for the transparency purpose or to save the money of the patient, which doctor might be earning from them, but also to reach a scientific conclusion. This is my observation, and second observation is that this is also the not only COVID is not a pandemic; it is also somehow questioning our lifestyle. Democratic country are more affected worldwide. India and America more affected, and the rich people are more affected. So I'm saying that why this is happening. We are making healthy system, but we are also making healthy people or not. We are making healthy system. I mean healthy hospital, more powerful, more intensive care, more critical care. But are we making more healthy people or not? This is my question, my observation. So thank you, Dr. Gupta. If you have anything to question, please. Thank you.
Thank you, Swatantra. You have really brought a point which is so close to my heart. And I have been suggesting over several groups that whatever we are doing, it should be subject to auditing.
Yes.
And, exactly you have brought to the fore the very important point. There is a need, urgent need for an app, and all hospitalized patients data should be entered into that app. One, what treatment is given, what is the indication for hospitalization, what is the outcome, one.
And how much money taken from them?
That is your view. I have different view on this. So we will not enter into that discussion. Number two is, who has got remdesivir, who has used remdesivir, and who has got remdesivir, why, when, and what was the outcome. Number three, third important drug is Tosi, costly, very, very expensive drug, and may induce problems to the patient. And number four is plasma. Who got plasma, why he got plasma, when he got plasma, what was the outcome. So there is a need that every patient who is hospitalized, his data must be entered into that app. The government must do that, and the need for the doctor may not write his name, but definitely, the data is required for future research and for measuring the outcome of each intervention, each medicine, why, how, who, all these things are very, very important. I think these things are, and that is the importance of a media man, a social man, involvement in such discussions. And you have brought a very, very important point to the fore. Thank you very much, Swatantra, for this. Now I will take questions. Ross, you are there? Ross?
Yep, I'm here. Yep.
Yeah. So there is a question from the audience about the role of favipiravir.
Sorry, the role of,
favipiravir.
we never used it. So
Never
we
used it.
No, never
So
used it.
that explains the role of favipiravir. Is that right?
Yeah, I think one of the problems is people, when they're unwell, will desperately grab for all sorts of things, believing that they must be good for them and they do no harm. But we've got lots of examples over the years where people have used drugs experimentally and found they've done more harm than good. Back in the 80s, the original steroid trial, high-dose steroids, Roger Bone's study in septic shock, actually caused a 2% increase in mortality because people believed it worked. And there've been other times when we've used drugs untrialed. So I think we want to be careful not to just grab something and say, oh, it must be better than doing nothing. Sometimes it's best to just treat the things we know, which include hydration and giving oxygen when it's necessary and ventilation when it's necessary, and looking after the simple things, not going for elaborate therapies. So I don't think there's any indication for other smart therapies unless they've been shown in a trial to improve a meaningful outcome, which means that the patients get better faster or reduce infectivity or something like that.
So, thank you very much, Ross. But in favor of saving a lot of time, I will combine favipiravir, ivermectin, doxycycline, azithromycin, SCQ in combo or in isolation. 1, 2, 3, 4, 5, any one of them. Would you recommend any one of them or none?
I don't. I
No,
don't.
I'm not. I will come to you, Dr. Ray.
Okay.
First, Ross.
No, I believe Dr. Ray's right. I wouldn't use
All
them.
right. So you are putting the gun on his shoulders. Right.
No, I trust him. I trust him. I wouldn't.
Okay.
Yeah.
Okay.
Unless there's a super infection, yeah, or
Okay.
you've got a problem with the infections in your unit. But generally, no, I wouldn't use them. No.
Abhinav,
Not empirically. No, sir. No, you're not using it.
You are not using it. Girish?
No, we don't.
So there is Dr. Ray, it's your turn to summarize.
Well, I see people giving, doxycycline, azithromycin very, very rampantly. Even in a non-symptomatic case, almost 80% of mild cases, in fact, that we know they comprise of all the cases, 82% of mild cases, we don't require to give anything. I myself was also administered doxycycline and azithro. I lost my appetite for 7 days. I did not eat anything. I was so weak, but it did not help at all. I was absolutely sick, and I don't keep since September 2020. I do not give any of this. And something which we should not give, and I see people themselves taking it also in India, right? And they don't have to ask the doctors. The doctor doesn't prescribe. They say, doctor, why don't you give me doxy? Many of them said, sir, I have taken doxy, azithro and everything. Anything else you would like to give? I said, you take anything and everything. He said, no, doctor gave me antibiotics, piperacillin, tazobactam, gave me, cephalosporins, gave me, some people even say that meropenem, ticoplanin. It is all unfortunate. I think we are talking of resources, and we create a situation where resources are unavailable. Of course, I think this is something we should actually not practice at all.
So I am summarizing. There is a unanimous view of the panel here that no ivermectin, no doxycycline, no SCQ, no ivermectin, no favipiravir for any patient of COVID when in any stage of the disease. We close this chapter and move on to role of convalescent plasma. What is your view, Ross, on role of convalescent plasma?
I've no experience with using it in COVID, so I shouldn't really comment, but in other disease states, it's been used somewhat overrated, but in some patients who are debilitated, it may be indicated. But I don't think as a general thing it's indicated. Is as far as giving antibodies and prevention, it's been there was a recent study 6 months ago now that showed that it didn't seem to give much protection as a preventative treatment. So
monoclonal antibodies, they have been cleared for emergency use even in India of late. Maduri has of late floated his idea of high dose steroid therapy initially in COVID patients. I'm sure none of the panelists would support it here in view of the possible side effects or toxicity of high dose. Now, Abhinav, what is your view about plasma, convalescent plasma?
So basically, this was studied extensively in the UK, a recovery trial, and they found no benefit of using convalescent plasma.
So because we are cutting the discussion to bare minimum and going on a little fast. Girish, what is your view?
Same. In the beginning we used quite a bit, like anything else, but now the percentage of patient getting plasma is reduced dramatically since the study.
So the wise population is one who learns from others' experience.
That is correct.
We do not have any of plasma, and I have heard when even routine plasma, normal plasma has been administered to COVID patients here in some cases, and even very important persons was administered. Dr. Ray, would you like to comment?
Well, I have not given one plasma to any of my patients.
So you
join
my bandwidth.
Yes, but I know that plasma is still being used sporadically in our part of the country. ICMR has not completely deleted plasma from its instructions. Somewhere, some corner, it say you may try in the first 7 or 8 or 10 days, but ICMR is not quite emphatic on using plasma. So I think plasma is getting more and more people are disillusioned with, and plasma banks are lying idle now, and people are not really talking about it.
Yes.
Now.
All right. So no plasma. I will draw this conclusion that no plasma is required. We will go on to some question about vitamins, etc., B12, vitamin D, etc. So what is your view, Ross, on vitamins, use of vitamins, immunity boosters?
So in a healthy patient, probably initially there is no indication for high dose additional vitamins. If the patients are malnourished, then perhaps, which may be the case in India, there may be indication to use standard dose vitamins as a supplement. But I wouldn't think they have no magical powers. Certainly vitamin C and vitamin D don't appear to have magical powers in stopping the progression of the disease.
All right. Thank you. Abhinav?
So we are studying vitamin C at the moment, sir. We, as part of recovery and remap trial.
Triple therapy? Triple therapy?
No, nothing of that sort. We are only studying vitamin C at the moment, and we haven't got the results yet. It is on an experimental basis that we are using, not as a routine.
Well, it's something that do we use? Yes, sometimes we do. Do we have data? No.
Okay. Dr. Ray?
Well, I use vitamin C, but I'm not sure whether it actually works, but I use vitamin C.
So we can continue to use vitamin C. The consensus is favoring that we may not eliminate vitamin C or other vitamins, but overuse may be not very useful. One important thing that we have been advocating is awake pruning, which we have missed in our initial discussion. So we sincerely feel that awake pruning is a very, very important intervention that should be suggested to every patient who moves towards a little more moderate disease than very mild or asymptomatic disease. It improves the function of lungs and improves the oxygen saturation in a desaturated patient by as high as 3 to 4% in no time of few hours. So what is your view about this, Abhinav? Awake proning.
Yeah, we strongly recommend awake proning in patients who are unable to maintain saturation. Most of our patients who are hypoxic, we would recommend awake proning to them.
Do you think there is a possible problem in patients who, if we suggest proning to patients who do not desaturate?
It is not indicated. Basically, any person who's comfortable and at a saturation of more than 94%, not symptomatic, there's no need actually. But unless the patient, yeah.
Ross, what is your recommendation?
Yeah, I think it should be used. I think generally patients should be mobilized as much as possible, which turning them over to a prone position is one way to do that. But if they're awake and not in hospital or are mildly sick, they should be encouraged to turn, sit up as much as possible, because this makes the respiratory function generally better. And certainly if they require it, proning is useful even before intubation. So,
Girish?
Yeah, I agree with Dr. Ross, as he said. We need to mobilize the patient as best as we can. And the proning in certain patients will definitely help. So I agree with Dr. Ross just said.
Dr. Ray, your final
summarize. Awake proning I do to all my patients, right? And awake proning is one thing which consistently increases the oxygen saturation, knowing fully well that the posterior part of the lung is very much involved, and if you prone, then obviously it has a very scientific basis in improving the lung function, and that's what we see. 92% with air breathing becomes 96, 97 consistently. In fact, I have got presently a patient for the last 24 days. He was 22 by 25 CTSS. CT severity score was 22, and which was extremely extensive, I would say. But he has come out of it with just awake proning. Now he's today on 2 liters of oxygen. So I am sure that awake proning, I think, is extremely important and effective. But there are situations like obesity, pendulous abdomen, they cannot do awake proning. So we do the lateral and sometimes a little semi-prone, that also helps. So therefore, I would be always for awake proning.
So we have Dr. Ray and all friends, my panelist friends, we have accumulated a data of our patients. And on an average, oxygen saturation is improved by at least 3.5% by awake proning over 6 hours. So these provides a lot of confidence to the patient who are at home and at a borderline of desaturation. They are hovering around 92, 93. They cannot find a oxygenated bed in hospital. So it gives them a lot of confidence, and they are advised proning in their houses, and that improves dramatically their oxygen saturation. On an average, we have noted that it is 3.5%, which is very, very significant, we feel. So it is, zero cost, harmless procedure. And many of us sleep prone, in fact, in routine. I, for one, is one person who half the time in bed, I am prone for last 15, 20 years and never supine. So I'm not sure whether it is helping me out to remain energetic and working 18, 20 hours a day. So now, so I am summarizing the whole thing. So only less than 5%.
Dr. Rumta, we would like to invite Dr. Ashok Parijat to have.
Yes, that's what I'm coming to, sir. I'm just summarizing what we have discussed and what is our inference. and we have very, very eminent citizens here. We will like to know their view about the whole discussion and need for such discussions. So our conclusions, the conclusions are: one, only less than 5-7% of the patients require consideration for hospitalization. They can stay home definitely at 94 or less, above 94% oxygen saturation. 3, battery of tests and CT scans are not required unless absolutely suggested by experienced consultants. Remdesivir, tocilizumab, all these advanced drugs should be used only in limited number of cases. Data should be generated, and there should be more than one doctor in the decision-making process, and it should be well recorded, the outcome research, and it should be reported. Number 5, there is big no to drugs like all those I don't have to repeat: ivermectin, doxy, azithro, SCQs, and favipiravir for any patient. High dose steroids are not indicated. Routine steroids should be started only in oxygenated patients in the hospital. No to plasma. Plasma is role is all now in history. Pruning is suggested wherever it is possible and wherever it is required. So we'll move on to our eminent citizens who have spared their valuable time to be with us, and I'll move straight to Dr. Ashok Pareja from Bhubaneswar, who is the Advocate General of State of Odisha. Dr. Ashok Pareja, what is your opinion, sir? And thank you very much for joining and sparing your time.
Sir, good evening and many congratulations for a very educative session. We have discussed various issues, and on remdesivir, let me tell you my experience. I was asymptomatic, and my doctor in the hospital was pushing me to take remdesivir. I called Dr. Ray, and he told my doctor that remdesivir is still searching for a disease. So that's the way I got out of the hospital without remdesivir. Now, I would just ask one question. And with the virus mutating so quickly, what is the efficacy of the vaccine which all of us have taken in India?
Right. So would you like to answer this question, Ross? You are muted. Unmute yourself.
Narendra, otherwise I can answer some.
Yeah? You want to answer this question, Girish?
Yeah, I can, because we in United States, most of the vaccine that we have used is Pfizer and Moderna, and they have shown to be quite effective in mutated viruses. So I have a feeling that these viruses, they would help to some extent, but they have seen that they have been quite helpful, at least the Moderna and the Pfizer vaccines.
Till you are exposed to the variant strain.
We have.
Okay.
We have.
Abhinav, your
in India, we take the Oxford vaccine and Covaxin.
Yeah. So basically, we are using the same. Most of the people are vaccinated with AstraZeneca, basically, which is very similar to Covishield in India. And I think it has been generally recommended, get vaccinated. Most of the mutant strains are sensitive, so it protects against most of the mutant strains. So I think it's whatever it is, I think we have to get vaccinated. So, but at the moment, this is what we believe.
Right. So thank you very much, Pareja Saab, for being with us. And we have General Mathur here. General Mathur, are you there? Or he has left? Dr. General Anuj Mathur is here. Can he be unmuted? General Anuj Mathur,
Yeah, now I am unmuted.
Yeah, your comments, General Mathur.
Dr. Rungta, and the Critical Care Foundation. Firstly, I must congratulate you on an outstanding session. But my only point is that such kind of sessions do not reach a larger number of people where they must. My point is that corona can be defeated by prevention. And as the media person was saying, that we need to create awareness among masses to ensure that we prevent the process of corona. I'm not a technical gentleman, so I will not be able to comment on whatever things have been highlighted. I just want to tell you that there is no dearth of many things in the nation. Whether there is mismanagement or management, what must happen is that media must highlight the gaps. People must highlight the gaps, the people in the administration, but not in a manner that it creates panic among the masses. What actually, to my mind, has happened, because as I see after this session, that only 4 to 5% people need treatment. Other people can be taken care of at home. So if that was known to many people beforehand, there would not have been such kind of a crisis which we have witnessed in last 3, 4, 5 days. But what I am trying to tell you is that people of India must learn to follow COVID prevention practices, which a lot of them are actually now doing it. India has a great ability for restitution. We will get out of this situation sooner than later, and we'll be back on track. All that we need to do is to act responsibly. Do not overreact to a situation which has been created by you coming positive or something. And have faith, spread positivity, have faith in the doctor, and faith in the Almighty. That's all I want to say.
Thank you. Thank you, General Mathur, for being with us. And you are one person who can really, I know you have been socially very active, sending a lot of messages to a lot of people which are very, very effective in nature. You can carry this mission forward. I request you to educate people about all these, what we have discussed.
Will surely.
And this has come from horse's mouth, today evening. And we have been talking about it for almost 6 weeks now, but our voice has been drowned into noise of fear mongers. That's my view. It looks a little stronger, but that's how it is. Justice Panajan Jain was here. Justice PC Jain Sahab was here. Is he here? No. But I will open the session if anyone of amongst the audience wants to make a comment on mic.
Hello, am I audible, sir?
Yeah, who is, can you identify yourself, sir?
Good evening, sir. I'm Dr. Anand Mishra from Bhubaneswar, sir.
Yeah. So Anand, you have about 30-40 seconds to make your view. Yeah, please.
So first of all, thank you very much, sir, for this excellent discussion, which we learned a lot of new things also. And my question to all the panelists is, sir, regarding the invasive ventilation. So what is the percentage of patient coming out of invasive ventilation in this second wave of COVID, whether it is same as the last year or it is more than last year?
I think I will just answer. It is the percentage of patients coming out of ventilation is not very high. It is low, lower than what we experienced last time. But that question we will leave for the next time, because this is a technical question. We'll organize a program on this, because this will invite a lot of comments. I have my own
sir, excuse me, sir. Hello, sir.
Yeah.
Sir, good evening, sir. This is Dr. Lahiri, sir. I'm an anesthesiologist.
Yes,
sir, I have a question.
Yeah.
Sir, like both my parents were admitted for COVID and they got discharged. But the thing was, my dad isn't diabetic, but well-controlled sugars. Mom had CA ovary. She was treated well 4 years back, presently stable. Her D-dimers were elevated during the course of illness. So is it required that as a part of post-COVID care protocol or management, do these kind of individuals or patients need to be started on low-dose ecosprin or something like that for preventing any thrombotic episodes later on, sir?
Dr. Ray?
Yeah, low-dose ecosprin, if somebody is already taking, please continue giving it. But to start with, we don't give. I think this anticoagulation is good enough protection for preventing or moderating the thromboembolic process.
Ross,
so therefore, we don't give.
Your view? Unmute yourself, Ross. Please.
Yes,
I agree with that. It's the anticoagulation it's unclear whether additional anticoagulation other than prophylaxis makes much difference to the standard cases. But if someone has started it, there may be good reasons for it and they should continue it. That would be the advice I'd have. Yeah. And there may be an indication that we haven't considered. If they've been started on it, I would continue it. And aspirin is as good as heparin in this situation, probably.
Colonel Kala, I can see you. Can you, do you want to make a comment? Quick
Hi,
comment.
good evening, Dr. Runta, and good evening to all the presenters from around the world. It has been just a wonderful session, and what I learned today is that global opinion is you don't need most of the medicines that are being prescribed left, right, and center here. So question is, how do we take that opinion to larger masses and avoid suffering that people are undergoing?
Oh, please help us in spreading the message.
Is education.
Yeah, education.
Awareness,
right.
Awareness.
I have my old colleagues, Dr. Mini Bhargav. Dr. Mini, you want to make a comment? Dr. Mini? Dr. Mini Bhargav. Dr. Pradyuman Sharma has just arrived. Pradyuman, you have 30 seconds to make a comment. You are getting late.
भाई अभी तो तुम ही बोल दो मुझे ABCD नहीं मालूम क्या डिस्कशन चल रहा है.
So because okay.
Get extra minutes.
All right.
Pradeep, you want to make a comment? Pradeep Devda, Girdhari Chug.
Dr. Saab, I'm Ajay Bhargav.
Yeah, Ajay, please.
I've been listening to this very enlightening discussion on COVID, and it is really enlightening to know that whatever is happening in India, especially with regard to administration of so many medicines, is actually not being followed in other countries. And it is now very important that how this information can be disseminated among the masses. I think a copy of this discussion today, if it is put on YouTube, maybe people will be able to see it and make themselves aware about what's happening around.
My host, Mr. Shekhar, please note it, and it's a worthy suggestion. Dilshad Kumra. Dilshad Kumra, you want to make a comment? All right. So we come back, and before we close down, I want a last concluding remark from each one of you. I'll start with Girish.
Well, I think this conference has given one thing for sure, that a lot of drugs are used which have no role in it. That's number one. And number two, a lot of tests that are done are not necessary. Number three, the oxygen, who requires, how it requires, we have already discussed this. And number four, that I will just add to it, is that as far as the antiplatelet versus anticoagulation is concerned, I think if people are taking aspirin is fine, but otherwise aspirin has really no role. How long do you need to anticoagulate the patient? Depends upon the situation. Or even if you want to follow some D-dimer, that it was a moderately sick patient and would you like to continue for 30 days or a little longer, that would be my suggestion.
Abhinav? Dr. Abhinav? He's not there or frozen. Ross, you are muted again. Can you unmute yourself? Yeah.
Yeah. Generally, I agree with Girish. I think good standard care, both at home and in the hospital, is important. The elaborate treatments, untested treatments, are potentially dangerous. I think we should just confine ourselves to doing simple things well and looking after patients in that way, rather than trying to experiment on them with untested medications.
So, Dr. Ray.
Yes, my concluding remarks will be 85% of patients don't require any treatment except paracetamol, a bit of cough syrup, or a bit of, Monte Calci or something, only symptomatic. And those patients who actually would require admission will be those who are actually less than 90% SpO2. And then we should actually give them steroids and anticoagulation. Remdesivir, if it is we give it because otherwise our life will be miserable, but I'm not very sure about its utility, and certainly not beyond 10th day. And if at all we haven't started on the 6th day, I don't start it. So that is it. And oxygen, we should not target oxygen saturation anywhere more than 93 or so, or 92 or 93. We should not waste oxygen actually, because this is something which we often are in aiming at an oxygen saturation of 98, 99, even 100%. And pruning, I would always advocate even to those who are actually threatening to come down with oxygen saturation. So my treatment will be pruning, steroids, anticoagulation, and oxygen if it is less than 90%.
Dr. Pruning Sharma, 30 seconds to you if you have heard all the panelists, because he's a very senior physician of Rajasthan and he teaches a lot of population about medicine. You are muted, Dr. Pruning Sharma. Please unmute yourself.
Yeah, my sincere regards and thanks to Dr. Rungta. You have been always very academics and for a beautifully organized, because the basic problem is the senior physicians here in Rajasthan, they make a printout, big printout, including azithromycin, doxycycline, Fibiflu. So these prescriptions are followed. Daily we are observing people are ready having Metrol 16 morning, evening, and besides Dexa 2 cc intramuscular also. I do not know. I have just super specialist has given a prescription, 2 shots I have given right now. So these things are what we are talking is different, what we are practicing is different. So first of all, let's make it as a protocol, in a state-wise protocol. This thing should be followed. People even writing ivermectin 1-BD. We don't understand. If you don't write it, so aapne likha nahi. So my message is that a very true, lesser the drugs, we are better off. Oxygen is a medicine, we should not let it go waste. That's very true enough. Remdesivir is to cut down hasten the recovery, but only in 30% group of sets where there's a desaturation associated more complications there. But it is not Ramban. We should understand. Right. And so the steroids, the dose is very definite. But the people are using a very high doses, even on the very first day, to cut down the temperature, which is something in the first week where you should not use steroids. So my take-home message, dear Dr. Rungta, please keep on organizing updates. Mera aapko bahut bahut sadhuvat for organizing, lovely and very educative. But people should get it into the practice. That's my carry-home message. Thank you.
Thank you very much, Dr. Pruning Sharma. And at this stage, I wish to thank you, everyone who has contributed so largely to this small effort that we have tried to make. And Colonel Kala wants to make a comment. Yeah.
I have a simple question. Is this recording available, this session of today? Is it recorded?
I think so.
So because then we must share it widely, at least on the social media and other media.
Because I can see the recording is going on.
So good. If you share the link with all the participants, we would be glad to share it further. and take the message to masses.
But before we conclude, I want to request, at least I know about General Mathur and Colonel Kala both. They are both involved in social activities, and I will request both of them to use their, hobbies, their, motivation, and the hard work they have been doing on social media to take such programs forward. And we have limitations of our own because of various reasons, and you are few people in the society who can take it to thousands in one go through various media and methods. So I will request, and we are there, and my friends are there. Ross is there from New Zealand. It is 4 o'clock early in the morning in his country there. Girish, has early morning in USA, and Abhinav, it is Saturday that he was little free in London. So we have been able to organize. Dr. Ray is always available whenever you just have. He's a phone call away to give a final point of view, what he thinks. So thank you very much, everybody, for being with us, and let this message go straight and strongly. Abhinav, probably you were disconnected. Can you make a final comment? Abhinav?
Sorry, sir, the computer died on suddenly. Reconnecting myself to the battery.
Just want a final comment.
So basically, I think the only thing is we have to be very judicious in whatever we are doing, and the confidence that what we are doing is right as per the evidence-based medicine. Oxygen only to be used whenever necessary to maintain a saturation more than 90%. That's it, sir. And steroids only for patients who are symptomatic requiring oxygen support, not for high fever, not for anything else. Only if you're on ventilator support, and no other drug is necessary.
Right. So I wish to conclude with a few sentences. One, as we have discussed, 85% of our patients do not need anything, but this is the 85% of our population, almost 3.5 lakhs, 350,000 of them getting one or many of these every time: ivermectin, doxycycline, favipiravir, etc., etc. So let us run a drive to stop it. One. So nothing is needed when the patient is either asymptomatic, just PCR positive. So no drugs needed. The next, you need hospitalization when you have oxygen saturation below 92 or 93. Above that, you don't need hospitalization. Let us discourage people from getting hospitalized, or tell hospitals not to admit patients at oxygen saturations above, and they must explain why have they admitted. Number 3, tocilizumab is a drug which has to be used in first 1 or 2 days. There is no reason for tocilizumab to be used later. Number 4, remdesivir is to be used, if at all, that has to be used in discussion with, at least in writing, by at least 2 physicians. Their consensus that yes, this patient needs remdesivir. So, and only in the first 10 days. Let us promote that. And last but not the least, let us convince our people not to panic. This is just another influenza. Most of our population is likely to recover. It is panic, it is stress, attempt to utilize facilities which are already under stress, poor availability of oxygen, or there are many other socio-economic factors. People say hoarding, etc., that must be dealt with firmly. And as many of our colleagues have suggested, there should be a national protocol which must be practiced by everyone. And many of the members in the audience will help us in spreading this message forward in the society in coming days and weeks. Thank you very much, ladies and gentlemen, for participating.
Can I make one last one?
Yes, yes, sir. Why not?
What I personally feel that a lot goes wrong because we get our political biases in. When you are handling a deadly pandemic, please, I beg of everybody, keep your political biases away, keep your politics away, and see how we can most responsibly as a nation, as a society, as individuals can handle this pandemic. And if we do that, I can guarantee you we will be out of it in no time.
Sir, I knew the general will come out some or the other time, and it has happened. So thank you very much, ladies and gentlemen, for helping us out, encouraging us, motivating us. Thank you, my panelists from all parts of the world, for joining us to spread a very, very important and sound message to the audience, who will definitely take it forward, what we need to do, what we don't need to do, and what definitely we should not allow to be done. Thank you very much.
Thank you, sir.
Thank you, sir. Thank you.